Have you ever found yourself just, swimming in a sea of medical information, feeling completely overwhelmed?
Well, absolutely.
Maybe you're trying to understand a new health challenge, or maybe just wanting to really grasp a complex topic, and you just wish you had a guide, something crystal clear to really make sense of it.
Yeah, like to get it on the level that the pros do.
Exactly, to understand it with that kind of clarity and insight that, seasoned professionals possess. Today, we are taking a deep dive into exactly that kind of topic. Clostridioides difficile infection, or you'll often hear called CDI.
C. diff, yeah.
Our mission today is really to arm you with a truly comprehensive understanding. Not by making you memorize every single detail like a textbook, no,
Right.
but by breaking down the complexities into clear, actionable insights, the kind that let you master this information, understanding the why and the how, like someone truly fluent in the subject.
And what's fascinating about Clostridioides difficile, C. diff, is just how pervasive and impactful this particular infection is, especially, within healthcare environments. We're going to pull back the curtain today.
Okay.
We'll explore not just what CDI is, but the maybe surprising reasons it occurs, how it actually affects the body, and this really intricate dance between our own biology, the powerful role of antibiotics, and this incredibly resilient bacterium. Our insights today, they come directly from a comprehensive medical text, specifically a detailed chapter focusing on CDI, and also something called pseudomembranous colitis. Our goal is to pull out the most important nuggets, connect the dots, and really explore the nuances that deepen your understanding, give you that sort of insider's perspective on a topic many people only vaguely recognize.
Okay, so let's start with the fundamental question. What exactly is CDI? When I talk about Clostridioides difficile infection, what are we actually talking about?
Well, at its core, we're talking about a very specific type of disease that primarily hits the large intestine, the colon.
Right.
It's not just any general gut upset. It has a very, very distinct fingerprint, a specific cause and effect.
Okay, so specific to the colon.
Wow.
What makes it unique?
That's right. So, to put it simply, CDI is a unique colonic disease that's most commonly triggered by the use of antimicrobial agents.
That are known as antibiotics.
Exactly, antibiotics. And this is a really critical point, and frankly, quite ironic when you think about it.
Yeah.
The very medications designed to kill bacteria and make us well can, under certain circumstances, actually pave the way for this serious infection.
How does that work?
Well, antibiotics, by their very nature, they disrupt the delicate balance of the normal, healthy bacteria living in our colon, what we call the colonic microbiota.
Like an ecosystem in there.
Precisely. Imagine it like a thriving rainforest. When you introduce a broad-spectrum antibiotic, it can sort of wipe out many of the good bacteria of the native species, creating this open space, this ecological niche. And in that cleared space, C. difficile, if it's present, can seize the opportunity to grow, basically unchecked. This disruption makes CDI the most commonly diagnosed diarrheal illness acquired in the hospital setting.
Wow.
Which is a truly alarming statistic. It really highlights its prevalence and its impact within healthcare.
So antibiotics clear the path, but then what? How does C. difficile actually go from just being present, maybe hanging out in the gut, to actively causing disease? What's its, strategy?
It's a very specific and rather insidious process. The disease starts typically with the ingestion of C. difficile spores.
Spores, like seeds.
Exactly like seeds. Think of these spores as incredibly tough, dormant seeds of the bacterium. They can survive really harsh environments, like the acidity of the stomach, which is remarkable.
Wow.
Once these spores reach the small bowel, they vegetate, which is the technical term. It means they transform from their dormant state into their active multiplying form.
Okay, they wake up.
They wake up, exactly. From there, they travel down and colonize the lower intestinal tract. Once they're established, these active bacteria start to produce and secrete these powerful chemicals called toxins.
Ah, the toxins.
Yes. Specifically, there are two primary large toxins, imaginatively named toxin A and toxin B.
Catchy names.
Yeah. These toxins are the real troublemakers. They directly attack the lining of the colon, causing the whole range of symptoms we associate with CDI, from relatively mild diarrhea to, in severe cases, a very serious condition known as pseudomembranous colitis, or PMC.
So it's the toxins that are the weapons doing the actual damage. Let's zoom out a bit more on the organism itself then. What kind of bacterium is Clostridioides difficile? What are its key features?
Well, C. difficile has a few key characteristics that make it particularly formidable. First, it's an obligately anaerobic bacterium, meaning it thrives in environments completely devoid of oxygen. This makes the human gut, especially the lower colon, its ideal home. It's also gram-positive, which is a classification based on its cell wall structure, important for lab identification.
Okay.
But perhaps its most significant trait, and what makes it so challenging to control, is its ability to form those incredibly resilient spores we talked about.
The seeds again.
Exactly. Unlike the active bacterial form, which is more fragile, these spores are like tiny protective armored capsules. They are found widely in nature, and crucially, they are particularly prevalent and persistent in hospital and chronic care facility environments.
So why is that important?
Because this resilience allows them to survive on surfaces, floors, bed rails, equipment for extended periods, sometimes months. They resist many common disinfectants, making remarkably difficult to eradicate from these environments. This spore-forming ability is a major reason why it remains such a persistent threat in healthcare settings.
That distinction about the spores being so tough is really key to understanding why CDI is such a stubborn problem. Now let's turn our attention to where and when CDI tends to show up. It certainly seems to have a preference for certain environments, doesn't it?
It absolutely does.
Yeah.
CDI occurs with striking frequency in hospitals and nursing homes,
Mm-hmm.
or very shortly after a patient has been discharged from one of these facilities.
Okay.
And this isn't a random occurrence. It's directly linked to two core factors we've touched on. First, these environments have a high volume of antimicrobial use.
The antibiotics.
Right, the antibiotics, which, as we discussed, disrupt the normal gut bacteria, leaving the door open for C. difficile. And second, these settings are often widely contaminated with C. difficile spores.
Ah, the spores again.
Yeah. So you have this potent combination, a large number of susceptible individuals, because their gut flora is disrupted, and an environment teeming with the resilient spores. It truly is a perfect storm for exposure and infection, a real testament to the persistent nature of this bacterium in healthcare spaces.
It's quite the paradox, isn't it? The very drugs designed to heal can, in turn, create this vulnerability. Let's delve deeper into that antibiotic connection. What have we learned over time about which types of antibiotics are most likely to trigger CDI?
Our understanding of antibiotic risk has certainly evolved over the decades. Historically, drugs like clindamycin, ampicillin, and certain cephalosporins were among the first culprits identified pretty early on.
Okay.
More recently, specific broad-spectrum antibiotic classes have been strongly implicated, particularly the second and third generation cephalosporins and fluoroquinolones.
Those sound familiar.
Yeah, you might recognize drug names from these classes, like ceftriaxone or ciprofloxacin, levofloxacin, moxifloxacin.
Yeah.
These have been particularly linked to hospital outbreaks, partly because of the emergence of highly resistant difficile strains that weren't killed by them.
So some antibiotic classes are definitely riskier than others. Are there any that pose a lower risk? And what about that irony you mentioned earlier? Can even the drugs used to treat CDI cause it later?
That's a crucial point. While technically no antibiotic is entirely without risk, certain combinations, like penicillin lactamase inhibitor drugs, think ticarcillin clavulinate or piperacillin tazobactam, are associated with a considerably lower risk of CDI.
Okay, that's good to know.
However, and this is where it gets really complex, it's vital to understand that all antibiotics, without exception, carry some risk of subsequent CDI. And yes, absolutely, that includes the very drugs we use to treat CDI itself, such as vancomycin and metronidazole.
Wow, that complicates things.
It really does. This creates a significant challenge, especially when managing recurrent infections, and it just highlights the incredibly delicate balance of our gut microbiome. It's a stark reminder that even when we're trying to fix one problem with antibiotics, we're profoundly affecting a much larger biological system. It's also worth noting, though, that a minority of CDI cases, particularly those acquired out in the community, occur without any documented prior antibiotic exposure. So that suggests there are other pathways for acquisition, or maybe just undocumented exposures.
Interesting. So if it's not always from previous antibiotic use, how do people generally get exposed to this organism? How does it get in?
The primary way people acquire C. difficile is through what's called exogenous acquisition.
Meaning from outside.
Exactly, meaning it comes from an external source. This happens most frequently in hospitals or nursing homes, as we've noted, but it can also occur in outpatient clinics or even just out in the community. Now, what's absolutely crucial to understand for infection control is this. C. difficile is carried in the stool of both symptomatic patients, the ones having active diarrhea, and, equally important, asymptomatic patients.
People who feel fine but are still carrying it.
Precisely. They show no symptoms but are still shedding the bacteria, or more accurately, the spores, in their stool. This silent carriage is a major factor in its spread.
That seems really hard to control then.
It is.
Yeah.
And the rate of people carrying C. difficile in their stool dramatically increases with the length of a hospital stay. For adults hospitalized for more than 2 weeks, the colonization rate can be 20% or even higher.
20%.
Yeah, it's a stark contrast to the general community, where the rate is estimated to be maybe 1% to 3%. This huge difference really underscores why healthcare environments are such significant reservoirs for this organism.
That's a striking difference, really emphasizing the unique challenge in hospitals and nursing homes. What's the overall picture of CDI burden in the U.S., say, and have we seen any trends over time? Are things getting better or worse?
Well, the numbers really illustrate the scale of this problem. CDI is the most common healthcare-associated infection in the United States. Back in 2017, for instance, there were an estimated 462,100 cases. That's a staggering figure.
Nearly 500,000 cases.
Yeah. However, there's also some encouraging news. Between 2011 and 2017, the total burden of CDI in the U.S. actually decreased by about 24%.
Oh, that's good.
It is. This positive trend was primarily due to a significant reduction in healthcare-associated CDI, which strongly suggests that targeted infection control efforts in hospitals, things like better cleaning, hand hygiene, antibiotic stewardship, are actually working. But on the flip side, the estimated burden of community-associated CDI, meaning cases acquired outside of healthcare facilities, remained largely unchanged during that same period.
So progress in hospitals, but the community spread is still a persistent challenge.
Exactly. We've made inroads in the healthcare setting, but tackling it out in the wider community is proving tougher.
Beyond antibiotics and hospital stays, are there other specific risk factors that make someone more susceptible to getting CDI? And circling back to those spores, just how long do they stick around in the environment?
Absolutely. Several other factors can increase susceptibility. Older age is a big one,
Okay.
as is a greater severity of an underlying illness, basically. Being sicker makes you more vulnerable. Undergoing gastrointestinal surgery can also make individuals more prone to CDI.
Makes sense.
And even seemingly small details in patient care can potentially play a role, like the use of electronic rectal thermometers, if not cleaned properly, or having enteral tube feeding. Antacid treatments, particularly those proton pump inhibitors or PPIs.
Like for heartburn?
Exactly. They've been considered a modest risk factor.
Yeah.
But the research suggests this risk is really only significant when patients are also receiving antibiotics. It's likely the combination.
Got it.
And to your point about the spores, their resilience is truly remarkable. C. difficile spores can persist on environmental surfaces like hospital floors, bedside tables, bed rails for months.
Months.
Yes, months. And they can also be carried on the hands of hospital personnel who don't practice meticulous hand hygiene. This persistence, both on surfaces and potentially on hands, is why robust infection control measures like thorough cleaning with sporicidal agents like bleach and rigorous hand washing are so vital in healthcare facilities.
To soap and water, not just the alcohol gels.
That's a key point. We'll come back to alcohol gels are not effective against the spores. You need soap and water or bleach for surfaces.
Interesting detail.
And just a tiny interesting side note, asymptomatic fecal carriage of C. difficile in healthy newborns is extremely rare. It suggests different host factors or perhaps different microbial compositions at play in very early life compared to adults. It's kind of fascinating.
So now we're going to get into the really intricate part. What happens inside the body once those incredibly tough C. difficile spores are ingested? You mentioned they germinate and secrete toxins. Can you trace that journey for us in more detail?
Certainly. It's a pretty precisely choreographed sequence of events that ultimately leads to disease. Once those toxigenic C. difficile spores, meaning spores from a strain that can produce toxins, are ingested, they have this remarkable ability to survive the highly acidic environment of the stomach.
Which usually kills a lot of bacteria.
It does. But these spores are tough. From the stomach, they travel into the small bowel, where they undergo that critical transformation. They germinate. They shift from their dormant spore state into active, multiplying bacterial cells.
The awakening continues.
Exactly. These active cells then make their way down to and colonize the lower intestinal tract, the colon, where they establish themselves, finding a niche, especially if antibiotics have cleared out competitors.
Right.
Once settled, they begin to produce and release their primary weapons. Those two large and potent toxins we mentioned, toxin A, which is technically an enterotoxin, and toxin B, a thetotoxin.
So these are the toxin twins that do the damage. How do they actually attack the body's cells? What exactly do they do to cause symptoms like diarrhea and that pseudomembranous colitis?
Yeah, their combined action is quite destructive. They initiate this cascade of events right there in the colon.
Yeah.
First, they directly disrupt the integrity of the epithelial cell barrier that lines the colon.
The gut lining.
Exactly, the gut lining. This barrier is like a tightly knit fence that keeps everything inside the gut where it belongs.
Yeah.
When it's disrupted, it leads directly to the primary symptom, diarrhea, and in more severe cases, the formation of those visible pseudomembranes on the colonic surface.
Okay, so they break down the wall.
They do. Diving a bit deeper into their mechanism, toxin A also acts as a potent attractant for immune cells called neutrophils, drawing them to the site and really fueling the inflammation.
Calling in the troops, but in a bad way.
Kind of, yeah. But the core mechanism for both toxins involves their ability to chemically modify specific proteins within the gut cells. These are called GTP-binding proteins of the Rho subfamily.
Okay, that sounds technical.
It is a bit, but think of these Rho proteins as tiny managers that regulate the cell's internal scaffolding, its skeleton, the actin cell cytoskeleton.
Right.
When these Rho proteins are chemically altered, glucosylated technically, by the toxins, this internal scaffolding gets completely messed up. The consequence is a loss of normal cell shape. The cells can't adhere to each other properly, and the tight junctions, the seals between cells, break down.
So the structure just falls apart.
Exactly. And this structural damage leads directly to fluid leakage from the intestinal lining into the gut lumen, which manifests clinically as diarrhea.
Makes sense.
Now, what's truly surprising, based on molecular studies, is that toxin B might actually be the more important virulence factor overall.
Really? How so?
Well, clinical disease has been clearly shown to be caused by C, difficile strains that produce toxin B but lack toxin A. But it's never been shown to be caused by strains that lack toxin B, even if they have toxin A.
So you need toxin B to really cause the disease.
It strongly suggests toxin B is absolutely essential for the full-blown disease process, whereas toxin A might contribute but isn't strictly required in the same way.
That's a fascinating detail. You also briefly mentioned a mysterious third toxin earlier, binary toxin CDT. What's its story?
Indeed. There's this third toxin called binary toxin CDT. It's found in some C. difficile strains, notably in all isolates of that infamous epidemic NAP1BI027 strain, which we'll definitely discuss more shortly. This toxin is structurally similar to another bacterial toxin called C. perfringens iota toxin. However, despite its presence in these highly virulent strains, its exact role in the overall pathogenesis of CDI, how it specifically contributes to the disease, is still, well, not fully understood. Researchers are still actively working to define its precise contribution. It's another piece of the puzzle.
Okay. Let's talk about pseudomembranous colitis, or PMC, which you said is the more severe form. What does that actually look like, both if you could see it with your own eyes, say, during an endoscopy, and under a microscope?
Right. PMC represents a more advanced and serious stage of CDI. When clinicians view the colon through an endoscope, or perhaps in an autopsy specimen, these pseudomembranes appear as these distinct, small, whitish-yellow plaques, typically only 1 to 2 millimeters in size initially, and they're confined just to the colonic lining, the mucosa.
Okay, like little patches.
Exactly, little patches. In the early stages, the tissue between these plaques might look relatively normal. But as the disease progresses, these plaques grow and merge together, forming larger, more continuous patches, these confluent plaques, that can eventually cover the entire colon wall.
Wow, the whole thing.
Usually, yes, the whole colon is involved, but interestingly, in about 10% of patients, the rectum, the very last part, is spared, meaning it doesn't show these pseudomembranes.
Huh. Microscopically, what are they made of?
If you were to look at a biopsy of one under a microscope, these pseudomembranes are quite distinctive. They're essentially layers, mats really, of dead white blood cells, necrotic leukocytes mixed with fibrin, which is involved in clotting, mucus, and cellular debris, all stuck to the damaged mucosal lining beneath.
Okay.
The underlying lining itself shows areas where the epithelial cells, the surface cells, are eroded and necrotic, basically dead tissue. And there's a heavy infiltration of neutrophils, those immune cells, confirming the intense inflammatory response occurring right there within the colon wall. It's quite a picture of damage.
This sounds like a key aha moment for understanding why some people get CDI and others don't, even when they're exposed. It seems like it's not just a simple one-step process of getting the bug.
You've hit on a really critical insight. The current understanding in how CDI develops really involves at least 3 essential events, rather than just, simple exposure to the bug.
3 events, okay.
The first event, which really sets the stage, is that exposure to antimicrobial agents are antibiotics. As we discussed, this establishes susceptibility by significantly disrupting the normal protective population of bacteria in the gastrointestinal tract.
Right, clears the field.
Exactly. This disruption creates a void, removing the healthy competition that would normally keep C. difficile in check.
So, step one, gut disruption by antibiotics. What happens next?
The second event is pretty straightforward. Exposure to toxigenic C. difficile. This means encountering a strain of the bacterium that actually has the genetic capability to produce those powerful toxins, toxin A and or toxin B.
Okay, exposure to a bad strain.
Right. But here's the fascinating twist. The vast majority of patients who experience these first two events, antibiotic exposure, followed by exposure to toxigenic C. difficile, do not actually develop CDI.
Oh, so that's not enough.
It's not enough.
Oh.
This strongly suggests that a third critical event is absolutely essential for the disease to actually manifest. It's not sufficient just to be exposed, even after antibiotics.
Okay, so what are the leading candidates for this critical third event? What's that final piece of the puzzle that determines whether someone gets sick or just carries it asymptomatically?
Well, the leading candidates for this crucial third event include things like exposure to a particularly virulent C. difficile strain, maybe one that produces way more toxin like that NEP1 strain,
Right.
or exposure to specific antibiotics that are especially potent at causing CDI, which we touched upon earlier. But perhaps the most likely, and certainly the most extensively studied third event, involves the host's own immune system, specifically an inadequate protective immune response.
The body's own defense.
Exactly. More precisely, it often comes down to whether the body can mount a sufficient anamnestic serum IgG antibody response, particularly to toxin A.
Okay, anamnestic. What does that mean?
An anamnestic response is essentially the body's immune memory kicking in. It's a rapid and amplified antibody response that happens upon re-exposure to something the immune system has seen before.
Ah, like a booster effect.
Sort of, yeah. So if your body doesn't produce a strong protective antibody response, especially to toxin A, upon encountering the toxin, you're much more susceptible to developing the full-blown disease. Your defenses aren't strong enough or fast enough.
So it's really about the immune system's ability to recognize the threat and fight back effectively. How does this immune response typically develop in people, and how does it actually confer protection?
It's believed that most humans first develop these crucial antibodies to C. difficile toxins, usually toxin A, early in life. Often this happens when they are asymptomatically colonized during their first year, or perhaps after a mild, maybe unrecognized CDI episode in childhood. Interestingly, infants are generally thought not to develop symptomatic CDI even when they're exposed and colonized. The thinking is they may lack these specific mucosal toxin receptors in their gut that seem to develop later in life.
Oh, that's fascinating.
It really highlights a developmental aspect of susceptibility. Now, as adults, we see a very clear pattern. Levels of the protective IgG antibody to toxin A tend to increase more in individuals who become asymptomatic carriers of C. difficile than they do in those who actually develop symptomatic CDI.
So a strong antibody response keeps you from getting sick.
It strongly suggests that, yes, a robust antibody response is protective. Furthermore, for those individuals who do develop CDI, if their antitoxin A antibody levels increase during treatment, that correlates with a lower risk of future recurrences.
Wow.
This really reinforces how vital this specific immune response is, not just for preventing the initial illness, but also for sustained protection against it coming back.
And has this understanding led to new therapies?
Absolutely. This immunological insight has been crucial in developing new therapeutic approaches. For instance, large clinical trials involving intravenous monoclonal antibodies, specifically engineered antibodies, targeting both toxin A and toxin B were conducted.
Okay.
When these were given alongside standard antibiotic therapy for CDI, they significantly reduced recurrent CDI rates compared to placebo. It's also worth noting, kind of reinforcing that toxin B point, that an antibody against toxin B alone was shown to be effective in reducing recurrence, but an antibody against toxin A alone was not effective.
Interesting. So even though the immune response to toxin A seems important naturally, the antibody therapy targeting toxin B was the key one.
Exactly. It adds more weight to the idea that toxin B is perhaps the more critical virulence factor to neutralize therapeutically, especially for preventing recurrence.
This clearly isn't just a localized health issue in one hospital. CDI has had a truly significant global impact. You mentioned rates and severity dramatically increased in the early 2000s. Can you paint a picture of just how widespread this problem became?
Oh, the numbers from that period are indeed quite sobering, and they really underscore the global reach of this pathogen. In the early 2000s, we saw this really marked increase in CDI rates and severity across the United States, Canada, and also Europe.
Okay.
To give you some concrete examples, U.S. hospitals, on average, saw their CDI rates essentially triple between the years 2000 and 2005.
Triple.
Triple. In Montreal, Quebec, hospitals reported rates in 2005 that were an astonishing 4 times higher than their 1997 baseline. 4 times.
Wow.
And perhaps most alarmingly, the directly attributable mortality rate in Montreal, meaning deaths directly caused by CDI, not just associated with, it jumped from about 1.5% up to a chilling 6.9% during that period.
That's a huge jump in death.
It's a very clear signal that something very significant was changing in the epidemiology of CDI, affecting patient outcomes profoundly. It wasn't just more cases, it was more severe cases.
So what was driving this surge, this dramatic increase in cases and severity? Was it a new, more aggressive strain of the bacterium emerging?
Precisely. A crucial part of this story, maybe the central part, is the emergence and subsequent global spread of what's known as the epidemic NAP1BI027 strain.
Okay, that name comes up a lot. NAP1BI027.
Yes, it's identified by its specific genetic characteristics. It's toxigenic ribotype 027, pulsed field type NAP1, hence the combined name. This particular strain is believed to have accounted for much of that alarming increase in incidence and severity that we saw.
Where did it come from?
It seems to have originated, or at least first caused major outbreaks, in the United States and Canada, and then it rapidly disseminated across the globe, reaching the United Kingdom, continental Europe, and even parts of Asia, causing widespread and often very severe outbreaks wherever it went.
What made this particular strain, NAP1BI027, so problematic? What were its key characteristics that allowed it to cause such a widespread and severe epidemic?
It possessed this really nasty confluence of highly problematic characteristics, making it particularly virulent and incredibly difficult to control. Firstly, in laboratory tests, this strain was found to produce an astonishing 16 to 23 times more toxin A and toxin B compared to other typical background strains.
16 to 23 times more toxin.
Yes, this hyperproduction of toxins undoubtedly contributed significantly to its increased virulence and the severe illness it often caused. Secondly, it uniquely carried that binary toxin CDT, which, as we mentioned, is associated with more severe disease outcomes, even if its exact role isn't fully defined.
Okay.
And thirdly, and this was a major challenge for treatment and infection control, it exhibited high-level resistance to all fluoroquinolones.
The whole class of antibiotics.
Yes, a class of broad-spectrum antibiotics very commonly used in hospitals at the time. This meant that the very drugs often used to treat common infections were completely ineffective against this strain, potentially allowing it to flourish and leading to more severe and prolonged illness when NAP1BI027 was the culprit.
So basically a hypertoxin-producing, drug-resistant super strain. That sounds like a public health nightmare. What impact did this realization have on control policies? And what's the situation now with these epidemic strains? Have we gotten them under control?
The severity of the NAP1BI027 epidemic certainly spurred significant public health action. Absolutely. For example, in England, they instituted national control policies back in 2006, which led to a marked decline in CDI cases there.
What did they do?
A key intervention was the restriction of fluoroquinolone use, and this directly correlated with the near elimination of fluoroquinolone-resistant C. difficile strains, including NAP1BI027 by around 2013. It was quite effective.
Wow, restricting that one class made a big difference.
It really did. And we've seen similar encouraging trends in the United States as well. Data show a significant decrease in this specific epidemic strain among healthcare-associated isolates. It dropped from representing about 31% of isolates down to 15% between 2011 and 2017.
That's a big drop.
It is. And for community-associated isolates, it decreased from 19% down to 6%. So this demonstrates that targeted control efforts, particularly focusing on how we use antibiotics, what we call antimicrobial stewardship, can be highly effective in combating specific problematic strains.
That's a huge success story, really highlighting the power of focused public health initiatives and antibiotic stewardship. But bacteria are always evolving, aren't they? It's like whack-a-mole.
Yeah.
Are there new strains emerging that pose current or future threats?
Unfortunately, yes.
Yes.
That's the constant challenge. The microbial world is constantly shifting, adapting. And new strains have been and likely will continue to be implicated in outbreaks. For instance, there's a strain that's become more prominent, known as ribotype 078.
Okay.
It's actually quite common in food animals like pigs, and it also carries the binary toxin. It has been associated with high mortality rates in human infections, raising concerns about potential zoonotic transmission spread from animals to humans.
That's worrying.
And closer to home, in the United States right now, the most frequently isolated community-associated strain currently is actually ribotype 106. This strain was previously recognized as an epidemic strain over in the United Kingdom.
So strains can move around globally.
They certainly can. So while we may have learned valuable lessons and developed strategies to manage past epidemic strains like NAP1-BI027, continuous surveillance and the adaptation of our strategies are absolutely crucial as new threats invariably emerge. We can't rest on our laurels.
So after diving deep into the biology, the epidemiology, the global picture of CDI, let's get practical. Let's talk about what it actually looks like in a patient. If someone suspects they might have it or a clinician is trying to diagnose it, what are the defining symptoms they'd be looking for?
Well, the absolute hallmark symptom, the most common and defining manifestation of CDI is diarrhea.
Okay, diarrhea. But lots of things cause diarrhea. What's characteristic?
Right, it's usually quite characteristic in CDI. The stools are almost never grossly bloody, which is an important point that can help differentiate it from some other infectious or inflammatory causes of diarrheal illness, like certain types of E. coli or inflammatory bowel disease.
Okay, not usually bloody. What about consistency?
Their consistency can range quite widely, actually, from just soft and unformed to quite watery or sometimes even mucoid, kind of slimy. And patients or healthcare staff often report a distinct characteristic odor associated with it. It's not just a general upset stomach, it often has a very specific pattern and presentation.
Okay. Beyond just the diarrhea itself, are there other common clinical signs or maybe laboratory findings that would strongly point a clinician toward a CDI diagnosis?
Yes, absolutely. There are several other common indicators that clinicians look for as part of the overall picture. Patients with CDI frequently present with a fever, occurring in about 28% of cases, so not always, but fairly often. Abdominal pain is also quite common, reported in about 22% of patients. And a really significant finding, observed in about 50% of cases, is leukocytosis.
Which is?
That means an elevated white blood cell count in the blood, which is a general sign of infection or inflammation. So these systemic symptoms, fever, pain, high white count, when combined with that characteristic diarrhea, especially in a patient who has relevant risk factors like recent antibiotic use or recent hospitalization, strongly point towards CDI.
Okay, that makes sense. Now, you mentioned earlier an intriguing scenario where CDI can actually be overlooked, even when it's quite severe. What's that hidden danger, and how do clinicians spot it?
Yes, this is a really critical nuance that unfortunately can lead to delayed diagnosis and potentially very serious complications. In about 20% of cases of CDI, patients can develop what's called adynamic ileus.
Ileus.
This is essentially a paralysis of the intestines. The gut temporarily stops moving normally. When this happens, it results in the cessation of stool passage, the diarrhea stops.
Ah, so the main symptom disappears.
Exactly. And because diarrhea is the most prominent and recognized symptom of CDI, if it suddenly disappears because of ileus, the diagnosis of CDI can be frequently overlooked. Clinicians might no longer suspect an infectious diarrheal illness because, well, there's no diarrhea.
So what's the clue then?
The crucial diagnostic clue to the presence of unsuspected CDI in these patients, where diarrhea is absent due to ileus, is often an unexplained leukocytosis, that high white blood cell count we mentioned. Particularly if the white blood cell count is 15,000 cells per microliter or higher.
So a high white count with no obvious cause and maybe a stop bell.
Precisely. That combination should raise a big red flag for underlying, potentially hidden CDI. And these patients, the ones with ileus masking the diarrhea, are unfortunately at a significantly high risk for severe complications of CDI, including toxic megacolon.
Which sounds bad.
It is. It's where the colon becomes dangerously dilated and can potentially perforate. And also sepsis, which is a life-threatening systemic response to infection. Recognizing this specific clinical scenario, ileus plus high white count, is absolutely vital for early intervention and potentially life-saving treatment.
That's a truly important detail for clinicians and anyone trying to understand the full scope of CDI. Now, what about recurrence? You've mentioned it a few times. It sounds like even after successful treatment, CDI can often come back, which must be incredibly frustrating for patients and really challenging for doctors to manage.
Unfortunately, yes. CDI recurrence is one of the most persistent and challenging dilemmas in managing this infection. Overall, somewhere between 15% to 30% of patients who are successfully treated for an initial episode of CDI will experience a recurrence.
That's a high percentage.
It is quite high. And these recurrences can be either relapses, meaning the original strain of C. difficile that caused the first infection just wasn't fully eradicated, comes back, or they can be reinfections, where the patient actually acquires a completely new strain from the environment after recovering from the first episode.
So it could be either. Why does it happen so often?
The susceptibility to recurrence is largely attributed to the continued disruption of the normal, healthy fecal microbiota. Remember how the antibiotics started the problem?
Right.
Well, that disruption often persists even after the CDI is treated.
Right.
And sometimes the very antibiotic used to treat the initial CDI can further compound that disruption. This ongoing microbial imbalance leaves the gut vulnerable, susceptible to C. difficile overgrowth again, creating this difficult and often frustrating cycle for patients.
So, given these varied clinical presentations, the hidden danger of ileus, and the significant challenge of recurrence, how do clinicians actually confirm a diagnosis of CDI? What are the key criteria they rely on? It sounds like it's not always straightforward.
You're right, it's not always straightforward. And diagnosis relies on a precise combination of clinical signs and laboratory confirmation. There's essentially two key parts to the criteria.
Okay.
First, the patient must have diarrhea, which is specifically defined usually as 3 or more unformed stools within a 24-hour period for at least 2 days. And importantly, there should be no other recognized cause for this diarrhea, like laxative use or another infection.
Okay. Significant diarrhea without another explanation. What's the second part?
The second criterion is laboratory confirmation. This clinical presentation needs to be combined with detecting either toxin A or toxin B in the stool sample, or detecting the C. difficile toxin gene using a highly sensitive nucleic acid amplification test, like PCR, or by actually culturing the C. difficile organism from the stool, or in more severe cases, directly visualizing those pseudomembranes in the colon through an endoscopic procedure.
So, clinical picture plus some kind of positive lab test or visualization.
Exactly. You need both pieces.
You mentioned visualizing pseudomembranes through endoscopy again. How often is that actually done, and how reliable is it as a standalone diagnostic tool for CDI in general?
Well, visualizing pseudomembranes is indeed a highly specific diagnostic indicator for pseudomembranous colitis, that more advanced and severe form of CDI. If you see them, it's pretty definitive. However, the reality is, PMC is actually visualized via endoscopy in only about 50% of patients who have diarrhea, and a positive stool test for C. difficile toxin.
Only half.
Only about half. So while it's a strong indicator if seen, it's certainly not universally present in all CDI cases, even those concerned by lab tests. Endoscopy can be a rapid diagnostic tool, especially for seriously ill patients where there's a strong suspicion of PMC or maybe another severe abdominal condition that needs looking at directly.
Right.
But it's crucial to remember that a negative result on endoscopy, meaning no pseudomembranes are seen, does not rule out CDI. The pseudomembranes might be focal, meaning localized to certain areas the scope didn't reach, or the disease simply might not have progressed to that visible stage yet.
Okay, so endoscopy is useful sometimes, but not the whole story. It sounds like diagnosing CDI isn't as simple as just ordering a single perfect test then. What's the landscape of the different diagnostic tests available? What are their strengths and weaknesses, especially for a clinician trying to make a rapid, accurate decision?
You've hit on a really significant challenge in CDI diagnosis. Despite the variety of tests available, and there are quite a few, no single test offers that ideal combination of high sensitivity, catching all cases, high specificity, correctly identifying only true positives, and rapid turnaround time.
The trifecta is missing.
Exactly. This lack of a perfect test can definitely complicate diagnosis and getting prompt management started for clinicians. It often involves choosing the best test, or combination of tests, for the specific clinical situation.
Okay, so let's break down the common types of tests. Maybe we can refer to the kinds of things listed in, say, Table 134.1 in our source material. What are the main categories and their pros and cons?
Sure, let's walk through the main players. First, you have stool culture for C. difficile. Pros. This is generally considered the most sensitive test, meaning it's excellent at detecting the presence of the bacteria, even at low levels. If the C. difficile that grows in the culture then tests positive for toxin production, its specificity is also very high, so potentially very accurate. Cons. The major drawback is the slow turnaround time. It takes days to get a result. This makes it pretty impractical for making urgent clinical decisions about treatment. It's more useful for epidemiological studies or maybe confirming other results.
Okay, sensitive but slow. What else?
Next is the cell culture cytotoxin test on stool. Pros. This test directly looks for the actual biological effect of C. difficile toxins on cultured cells in a lab. Does it kill the cells? It's highly specific, so a positive result is very reliable for diagnosing active CDI when you also have the right clinical symptoms. Cons. Like stool culture, its sensitivity isn't as high as some other methods, meaning it can miss some cases. And it also has a slow turnaround time, again, limiting its use in acute settings.
So specific, but also slow and maybe not sensitive enough. What about faster tests?
Right, that leads us to the enzyme immunoassays, EIAs, for toxins A and B in stool. Pros. These tests became very popular because they offer rapid results, often within just a few hours. And with clear clinical symptoms, a positive EIA result is diagnostic of CDI. So speed is the big advantage. Cons. Their significant limitation is their lack of sensitivity. They can miss a substantial number of cases where toxins are present, but may be below the test's detection limit. A negative result doesn't definitively rule out CDI. Because of this low sensitivity, testing multiple additional stool specimens with EIAs if the first one is negative is generally not recommended. It often just leads to more confusion rather than a clear answer.
Fast but misses cases. Okay. What about testing for the bacteria itself, not just the toxins?
That brings us to enzyme immunoassays for C. difficile common antigen, often glutamate dehydrogenase or GDH. This test detects a common enzyme, GDH, produced by essentially all C. difficile strains, both toxigenic and non-toxigenic. It's generally more sensitive than the direct toxin EIAs, meaning it picks up more potential cases. And like the toxin EIAs, it provides rapid results. Cons. The trade-off for higher sensitivity is lower specificity. Because GDH is found in both toxin-producing and non-toxin-producing C. difficile strains, and sometimes even other gut organisms can cross-react, a positive GDH result doesn't confirm active toxigenic CDI on its own. It basically tells you C. diff might be present. Therefore, a positive GDH result typically requires confirmation with a separate, specific toxin test, like a toxin EIA or PCR, to confirm active disease. It's often used as part of a two-step testing algorithm.
Okay, so GDH is a fast screening test but needs confirmation. What about the PCR test you mentioned, the nucleic acid amplification tests, or NATs?
Right, NET8s, such as PCR for the C. difficile, toxin A, or B gene in stool. Pros. These tests are now widely used, especially in the U.S. They are rapid, often providing results in hours, and they are highly sensitive, often considered more sensitive than even the direct toxin tests or culture in some settings because they detect the genetic material for toxin production. Their widespread adoption has definitely led to a noticeable increase in CDI diagnoses. Cons. Here's the big caveat, the major concern that's been raised. Because they are so sensitive, PCR can detect the presence of the toxin gene, meaning colonization with toxigenic C. Difficile even in patients whose diarrhea is actually caused by something else entirely, like a different infection or medication side effect.
Ah, so it can pick up colonization, not just active infection causing symptoms.
Exactly. This can lead to potential overdiagnosis of active CDI, where colonization is mistaken for active infection, potentially leading to unnecessary antibiotic treatment.
That's a really crucial distinction about PCR possibly detecting colonization without active disease. If it can lead to overdiagnosis, how do current guidelines help clinicians navigate this? How do they decide if a positive PCR really means active CDI?
This is indeed a key point addressed in current diagnostic guidelines. Because of this concern, many guidelines now recommend a multi-step approach, especially if using highly sensitive tests like PCR or GDH as the initial screen. For example, European CDI guidelines generally recommend confirming the actual presence of toxin in the stool using a toxin EIA, for instance, in addition to a positive PCR or GDH result to establish a more definitive diagnosis of active disease.
So detect the gene or antigen first, then confirm the toxin is actually there. Essentially, yes. Or use clinical context very carefully. Similarly, U.S. guidelines often recommend algorithms that might include a stool toxin test if there aren't clear prior clinical criteria strongly suggesting CDI, like recent high-risk antibiotic use, hospitalization, etc. The fundamental goal here is to try and differentiate active toxin-mediated disease from simple colonization, thereby avoiding treating colonization as active disease, which contributes to unnecessary antibiotic use and all its associated risks. It's really about being precise with our diagnoses and treatment decisions.
That makes a lot of sense. So if testing is going to be delayed, maybe it's a weekend or the lab is backed up, but the clinical picture looks very compelling for CDI, is there ever a situation where a clinician might just start treatment empirically, based on suspicion, without waiting for full lab confirmation? Yes, absolutely. Empirical treatment, meaning initiating treatment based on strong clinical suspicion before definitive lab confirmation is back, is completely appropriate and often necessary. if CDI is strongly suspected clinically and getting those stool testing results is delayed. In serious or rapidly progressing cases, waiting hours or days for a lab confirmation could unfortunately be dangerous for the patient. Clinical judgment, informed by the overall picture of the patient's history, symptoms, risk factors, remains paramount.
Okay, good to know. And what about tests of cure or testing patients who aren't showing any symptoms anymore? Is that recommended after someone has been treated for CDI, or maybe if they're simply a known carrier but feel perfectly fine?
This is another really crucial point. Testing asymptomatic patients is not recommended. The only real exception would be for specific epidemiologic study purposes, like tracking strains in an outbreak.
Okay.
And equally importantly, so-called tests of cure, retesting the stool after treatment to see if the C. diff or toxin is gone, are also not recommended.
Why not? Wouldn't you want to know if it's gone?
The reason is that more than 50% of patients, maybe even higher, will continue to harbor the organism and even its toxin in their stool long after their diarrhea has completely stopped and they are clinically well. They feel fine, their symptoms are gone, but the test might still be positive.
Okay.
And the results of these tests of cure do not reliably predict whether the patient will eventually experience a recurrence of CDI. A positive test doesn't mean they'll relapse, and a negative test doesn't guarantee they won't. Furthermore, using these test results to restrict patient placement, say in long-term care or nursing home facilities, is generally not advisable. It can unnecessarily burden patients in facilities without providing a clear clinical benefit or actually preventing true spread, which is more related to symptoms and hygiene. The focus should always be on symptom resolution and the patient's clinical well-being, not necessarily on eradicating the organism completely from the gut microbiota, which might even be impossible or undesirable.
Okay, so we've navigated the complexities of diagnosis. Once CDI is diagnosed, what's the game plan for treatment? What's the immediate first line of defense?
Well, the very first step, whenever it's feasible and clinically appropriate, is to discontinue any ongoing antimicrobial administration, any other antibiotic the patient might be on that could have triggered the CDI in the first place.
Stop the offending antibiotic.
Exactly. Early studies, before things got more complicated with severe strains, actually showed that a significant number of patients, maybe 15% to 23%, would improve simply by stopping the triggering antibiotic. Their gut flora could start to recover.
Interesting.
However, with the emergence of more virulent strains, like that NAP1-BI0257 strain we talked about, and the potential for rapid clinical deterioration in some patients, prompt initiation of specific CDI treatment has now become the standard of care. You usually can't just wait and see anymore.
Okay, so specific CDI drugs are needed. What else?
General supportive measures are also crucial. Things like ensuring the patient remains well hydrated, especially with significant diarrhea, to compensate for fluid loss. And it's generally recommended to avoid antiperistaltic agents, drugs that slow down gut movement, like loperamide.
Like Imodium.
Exactly. And also opiates. The concern is that these could potentially mask symptoms, making it harder to judge the response to treatment and possibly even worsen the disease by allowing toxins to linger longer in the colon because things aren't moving through.
Makes sense.
Though it's worth noting, for milder to moderate cases, these antiperistaltic agents can sometimes be used safely, but usually only when combined with specific CDI treatments like vancomycin or metronidazole and under close observation.
Okay, so what are the recommended first-line agents for treating primary CDI now, according to current guidelines? What are the go-to drugs?
According to the leading guidelines from organizations like the Infectious Diseases Society of America, IDSA, and the Society for Healthcare Epidemiology of America, SHEA, the recommended first-line agents are now either oral fidaxomicin or oral vancomycin.
Fidaxomicin or vancomycin, those are considered the current gold standards.
Yes, based on the best available evidence from clinical trials, those are the preferred choices for initial episodes.
And what about metronidazole? You mentioned it earlier. That used to be a very common treatment for CDI, maybe even the main one for a long time, didn't it? What's its role now?
You're absolutely right. Oral metronidazole was widely used for many, many years, often as the first choice, partly because it was much less expensive than vancomycin. However, multiple clinical trials, especially larger, more recent ones, have clearly shown it to be less effective than either fidaxomicin or vancomycin, particularly for more severe cases.
Less effective.
Yes. So its use is now generally only recommended for mild or moderate initial episodes of CDI, and specifically only when fidaxomicin or vancomycin are simply not available or perhaps contraindicated for some reason. It's really fallen out of favor as a first-line agent.
Okay. And you stressed oral vancomycin. What about 5-vancomycin?
That's a crucial point. Intravenous vancomycin, given through a vein, is ineffective for treating CDI because it doesn't adequately reach the colon where the infection actually is. It gets distributed throughout the body, but doesn't get secreted into the gut lumen in high enough concentrations. You need the drug right there in the colon. Fidaxomicin, similarly, is only effective when taken orally, as it needs to reach the gut directly to work. It's not absorbed systemically.
Got it. Oral route is key for both. Now, how do these primary treatments, fidaxomicin and vancomycin, compare head-to-head in terms of just clearing the initial infection and maybe more importantly in preventing that challenging problem of recurrence?
Right, so two large pivotal clinical trials directly compared oral vancomycin and fidaxomicin for initial CDI treatment. They showed very similar rates of initial clinical resolution of the diarrhea, getting the patient better initially. Both had about 90% efficacy.
So equally good at the initial cure.
For the acute infection, yes, they're pretty comparable. However, the key differentiator and a major advantage for fidaxomicin is that the rate of recurrent CDI within the following weeks was significantly lower in patients treated with fidaxomicin compared to those treated with vancomycin.
Ah, less likely to come back with fidaxomicin.
Exactly, which makes fidaxomicin a very attractive option, especially for patients who might be considered at higher risk for recurrence, although it is often more expensive.
Okay. And how did vancomycin stack up against metronidazole in trials?
The largest randomized controlled trial comparing those two head-to-head demonstrated that vancomycin had a superior cure rate for all CDI patients, regardless of initial severity. Vancomycin achieved about an 81% cure rate compared to only 73% for metronidazole.
That's a noticeable difference.
It was statistically significant and really helped solidify vancomycin's superior position over metronidazole, leading to the guideline changes.
What about how quickly people get better? Is there a difference?
In terms of response time, the mean time to resolution of diarrhea with effective treatment, either vancomycin or fidaxomicin, is typically around 2 to 4 days. However, the response to metronidazole can be noticeably slower. Because of this, clinicians usually don't deem a treatment a failure until a drug has been given for at least 6 days, especially if using metronidazole.
Okay. And how long is treatment usually?
Based on the clinical trial data, it's recommended that either vancomycin or fidaxomicin be given for at least 10 days for an initial episode. Metronidazole, if used, might sometimes require a longer 10-14-day course.
And you mentioned metronidazole was never actually FDA approved for CDI.
That's correct. Despite its widespread historical use, it was technically never formally FDA approved specifically for this indication. And its use for CDI treatment has declined markedly since those 2017 IDIS-ASHA guidelines shifted preferences clearly towards vancomycin and fidaxomicin based on the efficacy data.
So fidaxomicin or oral vancomycin are the preferred choices, especially for more serious cases. When should oral vancomycin maybe specifically be initiated really promptly, perhaps even before a definitive diagnosis is fully confirmed, as you mentioned earlier?
Right. It is particularly important to initiate treatment with oral vancomycin promptly for patients who appear seriously ill. The key indicators suggesting severe disease that warrant immediate treatment often include a significantly high white blood count specifically, greater than or equal to 15,000 WBCs per microliter, or an elevated serum creatinine level defined as greater than or equal to 1.5 milligrams per deciliter, suggesting kidney impact. So high white count or rising creatinine means start vancomycin quickly. Yes, those are strong indicators of more severe disease that shouldn't wait for all the tests if the suspicion is high. Prompt treatment is key to preventing complications in those cases. And while other drugs like nitazoxanide, bacitracin, rifaximin, and fusidic acid have been explored for CDI in small studies, they haven't been extensively proven superior or approved by regulatory bodies for widespread use in this context. Vancomycin and fidaxomicin remain the mainstays.
Okay, now let's tackle that really difficult issue, recurrent CDI, or RCDI. One of the biggest challenges is when it comes back after treatment. What's the approach for managing these recurrences, which sound incredibly frustrating for patients?
Recurrent CDI is indeed a major hurdle, no question. As we discussed, a substantial number of successfully treated patients, somewhere between 15% and 30%, will unfortunately experience a recurrence.
And fidaxomicin helps reduce that initial recurrence risk compared to vancomycin.
Yes, to reiterate that point, fidaxomicin has a significant advantage there. The first recurrence rate is substantially lower in patients initially treated with fidaxomicin compared to those initially treated with vancomycin. Metronidazole, in contrast, has recurrence rates comparable to vancomycin and critically is not recommended for the treatment of recurrent CDI episodes.
Okay, so avoid metronidazole for recurrences. What happens after the first recurrence? Does the risk go up again?
Yes, that's a very concerning aspect. Patients who experience a first recurrence then have an even higher rate of developing a second recurrence, sometimes estimated as high as 40–60%. It can become this difficult and sometimes debilitating cycle for patients.
That's very concerning. And you mentioned earlier it was once thought that recurrent CDI was relatively mild, but it sounds like that understanding has changed quite a bit. Is it still considered mostly mild?
It absolutely has changed. Recurrent disease, once perhaps underestimated in its potential severity, has now been clearly documented to pose a significant risk of serious complications. One study found an 11% risk of serious complications during a recurrent episode.
11% is high. What kind of complications?
Things like shock, developing toxic megacolon, perforation of the colon requiring emergency surgical removal of the colon, a colectomy, or even death occurring within 30 days of the recurrence diagnosis. This truly underscores the need for aggressive and thoughtful management of recurrent CDI, moving way beyond thinking of it as just a mild annoyance. It can be very serious.
Absolutely. So for patients stuck in that cycle, the ones with multiple recurrences where it just keeps coming back, what are the treatment options then? You said there's no single standard approach.
Right, for patients facing multiple recurrences, there isn't a universally standardized one-size-fits-all treatment protocol that works for everyone. But several effective and practical strategies have emerged and are recommended in guidelines.
Okay, what are they?
A long-standing and still effective approach involves the use of vancomycin in a specialized tapering and pulse dosing regimen.
Tapering and pulsed, how does that work?
Typically, after an initial standard 10-day course of vancomycin to treat the acute recurrence, you then slowly decrease the dose or frequency over several weeks. A common regimen might be 125 milligrams twice daily for a week, then once daily for a week, then maybe every other day or every third day for another 2 to 8 weeks.
So gradually withdrawing it, what's the idea behind that?
The idea is to keep suppressing the C. difficile long enough to allow the normal, healthy gut microbiota time to recover and reestablish themselves, restoring that natural colonization resistance against C. diff.
Okay, that makes sense. What are other options besides the vancomycin taper?
Other recommended options include using fidaxomicin, either at the standard dosage, 200 milligrams twice daily for 10 days, or potentially using it in extended or pulsed regimens, similar in concept to the vancomycin taper. Those specific regimens are less standardized. Another strategy is to follow an initial course of vancomycin, say 125 milligrams 4 times daily for 10 days, with a course of oral rifaximin, which is another antibiotic, often given 400 milligrams twice daily for 2 weeks. Rifaximin might help suppress C. diff while being less disruptive to the broader gut flora. And finally, fecal microbiota transplantation, or FMT, has gained significant attention and use for multiple recurrences.
Okay, let's talk more about FMT. It sounds like a potentially revolutionary approach, essentially transplanting a healthy gut ecosystem from a donor. But I've also heard about some concerns and maybe variable results. What's its current status and real-world effectiveness?
Right. FMT involves transferring stool and, critically, the complex community of healthy microbiota within it from a carefully screened healthy donor into the patient's gut. The goal is to fundamentally restore a normal, diverse, and protective gut flora that can outcompete C. difficile. It has indeed been widely used over the past decade or so, and the availability of standardized stool banks and even oral capsule formulations has certainly made this approach increasingly practical and accessible compared to older methods like colonoscopy delivery.
And how well does it work?
Initially, the results reported from observational trials and case series of FMT were incredibly impressive, sometimes showing success rates upwards of 90% for resolving recurrent CDI. However, it's important to maintain a balanced perspective here. The results from more rigorous randomized controlled trials, RCTs, while still generally positive and showing clear efficacy over placebo or standard antibiotics for multiple recurrences, are typically not quite as dramatically impressive as those initially seen in the observational studies. Cure rates in RCTs are often more in the range of 60–80%, depending on the study and comparison group.
Still good, but maybe not the near miracle cure originally reported.
Exactly. It's a common pattern as research moves from uncontrolled observation to more rigorous controlled testing. But FMT remains a highly effective option for many patients who have failed multiple rounds of standard antibiotic therapy.
So effective, but with maybe more modest cure rates in controlled trials. What about the regulatory and safety aspects? You mentioned screening. Is it FDA approved? Are there risks?
This is an absolutely crucial point that cannot be overstated. In the United States, FMT is not approved by the FDA for general use as a drug or biologic. It exists in a sort of regulatory gray area, currently allowed under enforcement discretion for recurrent CDI, not responding to standard therapies, provided certain conditions are met.
Okay. And the safety alerts.
Yes, the FDA has issued crucial safety alerts regarding FMT. These highlight the potential risk, albeit rare, of transmitting serious infections from the donor stool to the recipient. This has included transmission of multi-drug-resistant organisms, MDROs, pathogenic Escherichia coli, and even in very rare reported cases during the pandemic, SARS-CoV-2.
Wow, that's serious.
It is. This means that while FMT is a powerful tool, this approach should only be considered for patients who have demonstrably failed appropriate antibacterial therapy for recurrent CDI, usually meaning at least 2 recurrences after standard treatment. And critically, only when both the donor and the specific FMT product, whether from a stool bank or a directed donor, have been rigorously screened according to strict FDA guidelines to minimize these infectious risks. It really highlights the absolute need for careful patient selection, informed consent about the risks, and stringent safety protocols to ensure its responsible use.
Okay, that's very important context on FMT. Beyond antibiotics and FMT for recurrence, are there any other adjunctive therapies available? Maybe something that specifically targets the C. diff toxins themselves to help prevent recurrence in those high-risk patients?
Yes, there is exactly that kind of therapy available now. For patients who are considered at particularly high risk for having a recurrent CDI episode, an adjunctive treatment called bezlotoxumab is an option.
Bezlotoxumab, what is it?
It's a human monoclonal antibody, specifically engineered to target and neutralize C. difficile toxin B.
Ah, targeting the main toxin.
Exactly. And it's important to understand it's an adjunctive treatment. That means it's given in addition to, not instead of, standard antibacterial agents like vancomycin or fidaxomicin during the treatment of an active CDI episode.
So you give it alongside the antibiotic?
Correct. It's a single intravenous infusion given while the patient is receiving their antibiotic course. Clinical trials have shown that adding bezlotoxumab can reduce the risk of a subsequent recurrent CDI episode by an absolute rate of approximately 10% compared to placebo in these high-risk patients.
10% absolute reduction. Who qualifies as high risk for getting this?
The factors that identify patients who would likely benefit most from this adjunctive therapy generally include being over 65 years of age, being immunocompromised for any reason, presenting with clinically severe CDI at the initial diagnosis, or having a history of a prior episode of CDI within the last 6 months. It's a targeted approach, using immunotherapy to bolster the patient's defense, specifically against the effects of toxin B, aiming to break that cycle of recurrence in vulnerable individuals.
Okay, that's another tool in the toolbox for recurrence. Finally, let's address the most severe end of the spectrum. Severe, complicated, or fulminant CDI. This sounds like a true medical emergency. What defines it and how is it managed, especially given those challenges you mentioned, like ileus potentially stopping oral drugs from even getting to the colon?
Fulminant CDI is indeed a true medical emergency, and it represents the most challenging management dilemma in CDI. Clinically, patients present with signs of severe systemic illness. This can include things like dangerously low blood pressure, hypotension, progressing to shock, the autonomic ileus we discussed, meaning their intestines have essentially stopped working, so they may not even have diarrhea, and potentially developing toxic megacolon, that life-threatening extreme dilation of the colon.
What else might you see?
On physical examination, they may exhibit signs of an acute abdomen, suggesting serious intra-abdominal pathology. Diagnostic imaging, like an abdominal CT scan, might show signs of obstruction, the ileus itself, significant thickening of the colon wall, or ascites, fluid in the abdomen. They also often have that severe leukocytosis we mentioned, with white blood cell counts rocketing up to 20,000 per microliter or even much higher.
How is the diagnosis confirmed in these urgent cases?
If a patient presents with this picture, an acute abdomen, sepsis, toxic megacolon, maybe with or without diarrhea CDI should be a very strong consideration in the differential diagnosis, especially, again, if they have received antibiotics in the past 2 months. An abdominal CT scan is particularly helpful for patients who don't have diarrhea because of ileus, as it can reveal the characteristic signs of severe colitis. A cautious sigmoidoscopy, or even colonoscopy, can also be performed, if the patient is stable enough, to correctly visualize pseudomembranes, which would confirm the diagnosis rapidly.
And the management challenge.
The management is incredibly challenging because medical management alone is often suboptimal. The main issue is a difficulty in delivering the necessary oral antibiotic, like vancomycin, effectively to the site of infection in the colon when the patient has ileas or is in shock, impairing gut function and absorption.
So the standard oral drugs might not even get there.
Exactly, that's the core problem. So treatment often requires a multi-pronged, aggressive approach.
Okay, let's break down the specific treatment recommendations, maybe referring back to table 134-2 from our source. How does treatment differ for initial mild moderate versus severe versus fulminant, and then for the recurrences? Getting these details right seems crucial for that mastery goal.
Absolutely.
Okay.
Let's walk through the specifics outlined, for instance, in table 134-2. For an initial episode that is judged to be mild to moderate. The preferred treatments, as we said, are fidaxomicin, usually 200 milligrams taken orally twice daily for 10 days, or oral vancomycin, typically 125 milligrams taken orally 4 times daily for 10 days. For an initial episode that is judged to be mild to moderate, oral metronidazole, 500 milligrams orally 3 times daily for 10-14 days, is listed as an alternative, but only if the preferred agents are unavailable due to its lower efficacy.
Okay, fidaxomicin or vancomycin for mild, moderate first episodes. What about severe?
For an initial episode that is severe, remember, often defined by that high WBC 015,000 or creatinine of 1.5. The mainstays here are again oral vancomycin, but still usually the 125 milligrams 4 times daily dose for 10 days is effective, or fidaxomicin, 200 milligrams orally twice daily for 10 days. Metronidazole is generally not recommended here due to inferior outcomes in severe disease compared to vancomycin.
So same drugs, but maybe more urgency to start them, and definitely avoiding metronidazole if possible. Now for the most critical scenario, initial episode that is fulminant.
All right, this is the most aggressive management, defined by that combination of severe CDI plus hypotension, shock, ileus, or toxic megacolon. The recommended treatment here is usually a combination. Vancomycin, often at a higher dose like 500 milligrams given by mouth or via nasogastric tube 4 times daily, plus metronidazole, 500 milligrams given intravenously every 8 hours. The IV metronidazole is added because there's concern the oral vancomycin might not reach the colon effectively due to the ileus or shock, and IV metronidazole does provide some systemic levels that might help. The recommended treatment here is usually a combination. Additionally, clinicians often strongly consider rectal instillation of vancomycin. This involves giving vancomycin, maybe 500 milligrams dissolved in 100 milliliters of normal saline, as a retention enema every 6 to 8 hours. The goal is to ensure the drug reaches the distal colon locally, bypassing the potentially non-functional upper gut. The recommended treatment here is usually a combination, and the duration of treatment in fulminant cases might need to be longer than the standard 10-14 days, really dictated by the patient's clinical response. Early surgical consultation is also key here.
Okay, that's intense. Combination therapy, maybe rectal vancomycin, and thinking about surgery early. Now, moving to recurrent CDI, how does the table guide treatment there?
For first recurrence, the options often depend on what was used for the initial treatment. If vancomycin was used initially, switching to fidaxomicin, 200 milligrams orally twice daily for 10 days, is often preferred because of its lower subsequent recurrence rate. Alternatively, repeating oral vancomycin, 125 milligrams orally 4 times daily for 10 days, is an option. Another strategy listed is initiating oral vancomycin followed by that specific taper and pulse regimen we discussed earlier. VG, 125 milligram BID by 1 WK, then QD by 1 WK, then Q2 3 days for 208 WKs. The choice here often depends on the severity of the recurrence and patient factors.
Okay, several options for the first recurrence. What about multiple recurrences, meaning a second or subsequent recurrence?
This is where things get more complex, as we discussed, with no single universally standard approach. But several effective strategies are employed and listed as options. One strong option is oral vancomycin treatment, followed by that taper and pulse regimen. This remains a very practical and effective approach for many patients. Another option is fidaxomicin, either given as the standard 10-day course, 200 milligram a bid, or potentially using an extended pulse regimen like 200 milligrams twice daily for 5 days, followed by 200 milligrams every other day for the next 20 days. A different strategy involves treating with vancomycin, 125 milligrams 4 times daily for 10 days, then stopping the vancomycin and immediately starting efaximin, 400 milligrams orally twice daily for 2 weeks. And finally, fecal microbiota transplantation, FMT, is listed as a key option here. It can be administered via various routes, nasoduodenal tube, colonoscope, enema, or oral capsules. It's typically recommended, as per guidelines, only after a patient has failed appropriate antibacterial therapy for at least 2 recurrent CDI episodes, i.e. this is their 3rd episode or more. And again, that critical caveat. The donor and the donor specimen must be rigorously screened according to U.S. Food and Drug Administration recommendations due to those potential infectious risks.
Right, FMT is for multiple failures with careful screening. Lastly, the table mentions patients at high risk of recurrent CDI who are receiving standard antibacterial therapy. What's the recommendation there?
This is where bezlotoxumab comes in. For these high-risk patients, remember, 65 years, immunocompromised, severe initial CDI or prior CDI in the last 6 months, who are receiving standard antibacterial therapy, like vancomycin or fidaxomicin, for their current CDI episode. Bezlotoxumab, a single dose of 10 milligrams per kilogram given intravenously, is recommended as an adjunctive therapy. Again, it's crucial to remember bezlotoxumab is an adjuvant. It's given in addition to and during the course of the antibacterial treatment, not instead of it. Its purpose is specifically to reduce the risk of another recurrence after this current episode is treated.
Got it. That detailed breakdown of the treatment table really clarifies the specific strategies for different scenarios. It's complex, but logical. So after this incredibly comprehensive exploration of CDI, from the tiny spores all the way to monoclonal antibodies and fecal transplants, what's the overall outlook for someone who contracts it? What's the prognosis? And then crucially, how does the medical community work to prevent its spread, especially in those high-risk healthcare settings?
Well, the prognosis for CDI varies, but generally most patients do recover from an acute episode with appropriate treatment. However, it's vital to recognize that the mortality rate directly attributed to CDI has shown that concerning increase in recent years, particularly during major outbreaks like the NAP1 BI027 epidemic. While it was previously estimated to be perhaps between 0.6% and 3.5%, in some of those recent outbreaks, it sadly reaches high as 6.9%.
And higher in older people.
Yes, this rate is also progressively higher with increasing age, meaning older patients, unfortunately, face a significantly greater risk of adverse outcomes, including death. So while most patients recover from the initial episode, it's crucial to reiterate that those recurrences we spent so much time discussing are common, occurring in 15–30% or more. And these recurrences add a significant layer of challenge, morbidity, and risk to the overall prognosis and quality of life for many individuals affected by CDI.
That's a really sobering statistic, especially about the recurrences and the increased risk with age. Given this burden, how do we actively work to prevent CDI and control its spread, particularly in environments like hospitals and nursing homes where it's so prevalent?
Prevention and control strategies for CDI are really multifaceted. They have to be. And they generally fall into two main categories. First, strategies aimed at preventing the transmission of the organism, particularly the spores, to the patient in the first place. And second, strategies aimed at reducing the risk of CDI developing even if the organism is transmitted or already present.
Okay, let's start with preventing transmission. What are the key practices there?
For preventing transmission, several key practices are absolutely essential, especially in clinical settings. Consistent gloving of personnel is fundamental. Healthcare workers must wear gloves when having contact with patients diagnosed with CDI and their immediate environment, and change them appropriately. Things like the elimination of contaminated electronic rectal thermometers have actually proven effective in some settings, as these seemingly innocuous devices can easily spread spores between patients if not dedicated or properly cleaned. Rigorous environmental decontamination of patient rooms, especially after discharge, using a hypochlorite solution basically, bleach is critical. Bleach is uniquely sporicidal, meaning it effectively kills the highly resistant C. Difficile spores, unlike many other common hospital disinfectants which might kill the active bacteria but not the spores.
Bleach is key for the spores.
It is, and hand hygiene is paramount. But with that crucial nuance we mentioned earlier, hand washing with soap and water is specifically recommended over alcohol hand gels in situations where C. difficile exposure is likely, like during outbreaks or when caring for CDI patients.
Why again?
Because alcohol hand gels, while effective against many other germs like viruses and other bacteria, are not reliably sporicidal for C. difficile spores. The physical action of washing with soap and water helps to remove the spores from the hands. This is a really important detail for effective infection control and even public awareness.
Just soap and water, not just the alcohol gels for C. diff spores. Got it. What about controlling outbreaks, particularly related to how antibiotics are used within a hospital or facility?
Right. Controlling outbreaks often involves a highly targeted approach to antibiotic stewardship. That is, the careful and responsible use of antibiotics. CDI outbreaks have been most effectively controlled in many documented instances by restricting the use of specific antibiotics that are known high-risk culprits for triggering CDI.
Which ones again?
This often includes clindamycin, certain second and third generation cephalosporins, and fluoroquinolones. There's a clear and compelling example of this effectiveness. Outbreaks of CDI caused specifically by clindamycin-resistant strains have been shown to resolve promptly, sometimes dramatically, when the use of clindamycin was significantly restricted within that healthcare facility or unit.
Wow.
It really demonstrates the powerful impact that judicious and targeted antibiotic use can have in combating the spread and incidence of this infection. Stewardship is key.
Looking to the future then, what are the most promising areas for even better prevention strategies against CDI? What are researchers excited about on the horizon?
The future of CDI prevention holds genuinely exciting possibilities. Absolutely. Researchers are exploring several innovative areas that could really change the game. These include the continued development and refinement of monoclonal antibodies, similar perhaps to bezeltoximab, but maybe aimed at primary prevention in high-risk individuals before they even get CDI, or perhaps targeting different aspects of the bacteria or toxins. The vaccines are also a highly promising area of active research. The goal here is to stimulate a strong protective immune response against the toxins, or perhaps the bacteria themselves, before exposure occurs, essentially priming the body's defenses so it's ready if it encounters C. diff.
A C. diff vaccine would be huge.
It would be a major breakthrough. Finally, biotherapeutics, which involve using live organisms like specific beneficial bacteria or yeast to restore or enhance the protective gut microbiota, are a significant area of investigation. These could involve highly specific probiotics or other defined microbial interventions designed to directly compete with C. difficile, or bolster the gut's natural colonization resistance, making it much harder for the harmful bacteria to take hold in the first place. These are all dynamic areas that could truly change the landscape of CDI prevention in the coming years.
Wow. We have truly taken a deep dive today into Clostridioides difficile infection. We've gone from its microscopic, incredibly resilient spores, the surprising role of antibiotics in enabling it, tracked global epidemic strains like NAP1BI027, and unpacked the intricate strategies clinicians use to diagnose and fight it, including those detailed treatment tables. You, our listener, should now have a solid, comprehensive understanding of this complex disease, giving you the kind of insight that's truly valued by professionals in the field. You've got the foundation for mastery.
Absolutely. And if we connect this to the bigger picture, the story of CDI really highlights the profound and often underappreciated impact our gut microbiota, that community of trillions of microbes living inside us, has on our overall health. And it underscores the delicate balance that antibiotics, as vital as they often are, can inadvertently disrupt. It's just a powerful reminder that every medical intervention, especially antibiotics, has broader implications within our complex biological systems.
So what does this all mean for you, our listener, moving forward? Well, next time you hear about antibiotics being prescribed, or even what seems like just a simple stomach bug, maybe take a moment to consider that incredible unseen world within us. Ponder how even a tiny, resilient spore, like that of C. difficile, can create such a significant challenge, driving complex medical decisions, requiring sophisticated diagnostics and treatments, and shaping global public health strategies.
And this really raises an important question for all of us to think about. Given the ongoing evolution of bacterial strains, like the emergence of new ribotypes, our increasing understanding of the complex microbiome, and the continuous development of new treatments like antibodies and potentially vaccines, what future innovations in diagnostics and therapeutics do you think will truly tip the scales in our favor against persistent and adaptable infections like CDI? And perhaps even more critically, what responsibility do we each have, as patients and as a society, in practicing good antimicrobial stewardship, using antibiotics wisely and only when truly necessary, to protect not only ourselves, but also the effectiveness of these precious resources for the broader community from such resilient pathogens?